Good morning, good afternoon, and good evening. Thank you for joining the Wilson Center's Maternal Health Initiative, along with UNFPA, for this important discussion on sexual and reproductive health as essential to achieving universal health coverage and the importance of engaging stakeholders to realize health equity worldwide. We are immensely delighted to also be partnering today with the World Health Organization on this very important discussion. I'm Sarah Barnes, and I direct the Maternal Health Initiative, or MHI, at the Woodrow Wilson International Center for Scholars in Washington, D.C., and I'm joining you today from Bern, Switzerland. For those of you who are unfamiliar, the Wilson Center is a critical source of nonpartisan foreign policy research and analyses where we work to tackle global issues through independent research, open and honest dialogue like we have today, and actionable ideas. At the Maternal Health Initiative, which is a thematic program at the center, we focus on a multitude of global issues, including gender equity, health system strengthening, and of course, sexual and reproductive health and rights. It has been such a pleasure collaborating with the esteemed group of panelists you are about to meet and several UNFPA and WHO colleagues. Thank you all for making this event possible. It is also my pleasure to share that, guided by national government needs, political commitments, and the clear calls by civil society for the urgent need to integrate sexual and reproductive health and universal health coverage, the World Health Organization, in partnership with UNFPA, will soon be launching the Learning by Sharing portal that will provide evidence-based resources and also document various implementation stories representing latest evidence, best practices, and interventions being undertaken worldwide. And relevant for this audience, this also includes stories on the participation of all relevant sexual and reproductive health stakeholders, especially women and girls and other marginalized groups, in priority setting, planning, and implementation on universal health coverage, or UHC. We at the Maternal Health Initiative are really excited about this Learning by Sharing portal, and we look forward to this WHO and UNFPA partnership. I'd like to give a huge thank you to all of our panelists for being here today. Like I said, it has been such an honor to work with each of you, and I really look forward to the discussion. I would also like to thank everyone who's watching today, and I encourage you to participate in this conversation by submitting questions for our panelists. You can submit questions to mhi@wilsoncenter.org, and we will do our absolute best to answer as many questions as possible. You can also follow the conversation on Twitter by tagging @Wilson_MHI and by using the hashtags SRH-UHC and hashtag MHDialogue. Again, to submit questions, it's mhi@wilsoncenter.org. And a final thank you to my team at MHI, as well as our fabulous AV team for all the work that you do in putting these events together. Now, without further ado, I'd like to introduce our first speaker, Dr. Baloshni Govinder, to make some opening remarks. Baloshni is a scientist in the Department of Sexual and Reproductive Health and Research at the World Health Organization based in Geneva. She leads a portfolio of work on health system strengthening for universal access to sexual and reproductive health, with a focus on universal health coverage and primary health care. Her background is in health economics and health policy and systems research. Welcome, Baloshni. The floor is yours.
Can you hear me?
Yes, thank you.
Okay, can you see my screen, Sarah and everyone?
Yes.
Great, okay. I'm gonna just go to my screen because I can't see it. Just give me a minute. Great. Sarah, thank you very much for those opening remarks, and welcome again. Just like to add my voice to welcoming all participants joining from all corners of the globe. Good afternoon, good morning, good day, and thank you to our speakers for taking the time to share their experiences. And also thank you to the Wilson Center, Sarah, and to our partners in UNFPA, Geeta Lal and Wilbeck, for co-organizing this event. So my role today is to set the stage, and the stage as we know it cannot be easily summarized in a couple of minutes, but I'll do my best just to highlight some of the key issues and opportunities for advancing on this important topic on how do we engage with stakeholders more equitably and through more inclusive participatory processes in the quest for both universal health coverage and access to universal and comprehensive sexual and reproductive health services. Are my slides moving? Good, great, okay. So just to set the stage, we'll talk briefly about progress towards both sexual and reproductive health and rights and universal health coverage. And how can we not have a discussion in this day and age without talking about the effect of the pandemic? And finally, again, just to remind ourselves of some of the commitments towards both universal access to sexual and reproductive health and reproductive rights, as well as universal health coverage. So in terms of some of, just to highlight, and I'm going to be very quick, and just to highlight some of the progress towards both universal health coverage and sexual and reproductive health and rights. Important to highlight in 2015, the Sustainable Development Goals, which were adopted by the United Nations. And these included targets towards UHC, ensuring universal access to sexual and reproductive health care, and universal access to sexual and reproductive health and reproductive rights, with WHO and UNFPA as the lead agencies, or UN agencies, mandated to support and lead the implementation of UHC and SRH related goals and targets respectively. And following in 2019, the United Nations high-level meeting on UHC reaffirmed commitments to universal access to SRH and reproductive rights. In 2020, more recently, co-convened by UNFPA and the governments of Kenya and Denmark, the Nairobi Summit on ICPD 25 highlighted again and reaffirmed commitments to transform laws, policies, and norms related to women's and girls' human rights, bodily autonomy, sexual and reproductive health. And importantly, the summit not only included young people, but also positioned young leaders of diverse backgrounds, sexualities, and abilities as decision makers, experts, and thought leaders. And I think this also rings true for our discussion today. In 2020, WHO launched the UHC Compendium of Healthcare Interventions, which is a database of health services to support countries in developing their health benefit packages. And importantly, and a point to emphasize about health benefit packages, is that it draws policy attention and resources to priority needs and services. So it's an important starting point for UHC and ensuring coverage of or access to sexual and reproductive health. Accompanying the UHC compendium, we also developed specific guidance on the processes and practical steps essential to integrating SRH into national and subnational health sector policies and strategies. And these include, and I'll highlight 3 of them. These include creating deliberative spaces that enable the full participation of all stakeholders in priority setting processes towards defining health benefit packages. Secondly, highlighting the specific role of civil society, including women's rights organizations, youth groups, marginalized and vulnerable groups as central to these processes. And thirdly, is monitoring financial protection and access to quality SRH services, especially for women and other groups that are marginalized and vulnerable and are typically left behind. But however, as we know, commitments towards both UHC and to sexual and reproductive health were immediately put to the test with the onset of the COVID-19 pandemic and its consequences, which have unfolded over the past 18 months. As we know, the pandemic has spread to more than 190 countries. Almost 4 million lives have been lost. And what's relevant for us today is that the pandemic has laid bare and amplified pre-existing challenges, including challenged health systems, gaps in social protection, and has also amplified the inequalities, vulnerabilities, and barriers faced by women, by girls, marginalized and vulnerable populations in accessing services. With respect to sexual and reproductive health, we've witnessed widespread losses in access to services, including family planning, with consequences for unplanned pregnancies and increased levels of gender-based violence. At the same time, crisis, as we know, is also a driver of innovation, and the role that digital health, community outreach, and self-care can play has come under the spotlight during the pandemic. And this lends even greater urgency to the quest for UHC and ensuring universal access to SRH care services and paying specific attention to barriers that women, girls, marginalized and vulnerable groups face. And before we move on and share the video on universal health coverage, I'd like to remind ourselves that despite the challenges that existed pre-COVID and that have been amplified during the pandemic and that continue to unfold, there's also moments of opportunity. Firstly, there's an unprecedented political commitment towards universal health coverage and sexual reproductive health. There's growing technical and normative tools for advancing progress towards both these goals. And as governments step up policy and programmatic action towards sexual and reproductive health and universal health coverage, there is also a growing evidence base that's important for being able to share across settings and within countries as well. And as Sarah noted earlier in her opening remarks, WHO and UNFPA are partnering on developing a SRH in UHC learning by sharing platform, which will be a collection of qualitative stories documenting countries' experiences in implementing and integrating SRH within UHC. And progress depends very much on ensuring the participation of all relevant stakeholders in priority setting processes, especially those that are hard to reach, including ensuring representation of women's groups, youth populations, key populations, ethnic minorities, people with disabilities, and etc. And this also underscores the mandate and the work of both WHO and our colleagues in UNFPA. And I think that more importantly, this discussion today is important to be able to understand how hearing from our colleagues on the ground, representing very diverse groups, women's organizations, vulnerable populations, groups that are marginalized, and how we can ensure and learn from each other and to be able to move the agenda forward. Thank you, Sarah, and I'll hand over to you to share the video. Thank you.
Thank you very much, Galoshni. We'll put the video on now.
"2030, it sounds like years away, but the clock is ticking. Time is short and we have a promise to keep. A promise to ensure all people and communities in all countries receive the health services they need when and where they need them without facing financial hardship. But there's still a lot of work to do. At least half of the world's people lack full coverage for essential health services. More than 800 million people spend over 10% of their family budgets on health services, and close to 100 million people are pushed into extreme poverty because of healthcare expenses. We cannot accept a world like that. We cannot afford a world like that. That's why countries all over the world are investing in universal health coverage. By enabling communities to make decisions about their own health, like breastfeeding, healthy diets, and bed nets. By reaching the most remote villages with life-saving services like vaccines. By building networks of affordable primary care clinics to provide treatment locally for everyday health needs. And by providing more sophisticated services at hospitals for life's ups and downs. The thing is, universal health coverage not only improves health and increases life expectancy, it also reduces poverty, creates jobs, drives inclusive economic growth, improves gender equality, and protects countries against epidemics. With investments, every nation can increase its range of health services, expand its health workforce, improve its infrastructure, ensure essential medicines are available, and protect people from the cost of paying for care out of their own pockets. We call on the global community to make universal health coverage a political priority so everyone can access quality healthcare without facing financial hardship. If we work together, we can make universal health coverage a reality and ensure a safer, fairer, and healthier world for all.
Thank you so much. And thanks again, Viloshini, for your words and for showing this film to kick off our discussion today. So now I'd like to turn things over to our moderator for today, Dr. Willa Baldzek. Will leads UNFPA's Maternal and Newborn Health Program as the Global Maternal and Newborn Health Thematic Fund Coordinator, and previously served as the Unit Chief of Global Maternal, Newborn, and Adolescent Health for UNICEF. Prior to joining the UN, he worked clinically as an OBGYN for 10 years in both low and high income countries. Will, thank you so much for being here today and moderating. The floor is yours.
Thank you, Sarah, and also warm welcome from my side. It's really great to be moderating such an esteemed panel with members who have very impressive CVs and bios, and I will introduce each and everyone on the panel right now. So first we have Dr. Atiya Abru. She is currently serving as the Deputy Director of Programs for Reproductive, Maternal, Newborn, Child and Adolescent Health at the Ministry of National Health Services, Regulations and Coordination at the Government of Pakistan. And you can see every panel member on the screen, I hope with names, so you know who is who. Then we have Siva Tanentiran. Siva is currently the Executive Director of the Asian Pacific Resource and Research Center for Women, and a regional feminist organization working on sexual and reproductive health and rights and gender across 15 priority countries in Asia Pacific, with more than 70 partners across the world. Then we welcome Ruth Morgan Thomas. Ruth has been involved in sex work for more than 40 years and was one of the founding members of the Global Network of Sex Work Projects in 1992 and has been employed as the global coordinator since 2010. And she's currently co-chairing the UNAIDS Steering Committee on HIV and Sex Work on behalf of this organization, and represents also, and has also formed a sex worker inclusive feminist alliance. And then we have Zandile Simelane. Zandile is a 27-year-old HIV and AIDS activist, self-proclaimed positive living ambassador, and she is a young active citizen dedicated to changing the mentalities on the subject of living positively with HIV, and she's working towards normalizing the conversations around living with HIV and also HIV disclosure. And our final panelist is Jacques van Zuidam. Jacques is the head of the National Population Unit of the Government of South Africa. His responsibilities include population and development research, monitoring, evaluation, implementation of the country's population policy. I think we have really a great group of panel members, and I think we will really enjoy the discussions that we're going to have. Before we jump into that, just a reminder for our viewers and participants. Please submit your questions to mhi@wilsoncenter.org and include your name and affiliation with your question. And also follow us on Twitter. I think all the information that is needed is in what has been sent to you in the package or in the invitation. So please actively Twitter, be active and bring out the word about this event, and send in your questions, because we're looking forward to them in around 25 minutes. So I will now hand over to our first panelist. And what we're going to do is we have 5 minutes for each panelist. And I have my iPhone here. And after 4 minutes, I will have to unfortunately ring the bell. So you know it's 1 minute, and then we have to come to a closure. It is unfortunately on Zoom that we have to take these measures, because otherwise it's difficult to keep time. So first of all, our first panelist I would like to involve or bring on stage is Atiya. And Atiya, my question was to you: how is the engagement with youth being ensured during the development of adolescent health and development strategies? How do you think, what is useful, and how does that relate to SRHR? over to you.
Thank you, Zeke. I have made a short presentation for the group. Can I share it?
Yes, please.
Yes, you can. Yes, please go ahead.
So can you hear me?
Yes, nice.
Can you hear me now?
We
Oh,
can hear.
sorry.
Thank you.
Yeah, sorry for a little delay. Let me start with the inclusion of SRH services in the universal health coverage initiative, which Government of Pakistan is right now focusing on. As Government of Pakistan is highly committed to achieving the sustainable development goals, and we all know that achieving universal health coverage is crucial to reach the targets. Pakistan is among the first countries which have developed a universal health coverage benefit package in line with the disease control priorities third edition of WHO recommendations. And we are now under the process of development of an investment case for universal health coverage, which will be addressing the financial gaps to implement the interventions which have been prioritized under the UHC benefit package. So regarding the engagement of key and vulnerable populations within the UHC process, we formulated at the ministry level, at the federal level, we formulated a sexual and reproductive health technical subgroup, which was constituted last year. And it includes participation from the UN agencies, from international NGOs, from the Society of Gynecologists and Obstetricians of Pakistan, CSOs, academia, and similar type of provincial technical working groups also exist at the provincial levels. Then at the same time, we are reviewing the laws regarding the sexual and reproductive health, the laws and acts, just to harmonize with the global guidance and commitments. And we are right now working on tabling a bill regarding the maternal death notification mandatory to the hospitals and health facilities. We also conducted a situation analysis regarding the adolescent and sexual and reproductive health, and this informed to the development of an adolescent health and development strategy last year. Then regarding the strengthening of strengthening these engagements to reach the youth, we are underway of developing curricula of different levels, and these curricula are being developed in line with all those interventions which have been prioritized in the UHC benefit package. And as I said before, the UHC benefit package does include the sexual and reproductive health interventions at the top priority. So we are nowadays working on developing, and some of the curricula are being revised, some new curricula are also being under development. And then after developing these curricula, we will be imparting training to the healthcare providers at the pre-service and in-service level as well. The health service integration at the country level for inclusion of SRH into the health programs, we have included the SRH indicators in the electronic data management system. Similarly, we are also reviewing the National Essential Medicine list to include the medicines related to sexual and reproductive health services. The National Service Delivery Standards and Guidelines for Safe Uterine Evacuation in Post-Abortion Care has already been approved and endorsed by Ministry of National Health Services about 2 years back, and the trainings on these guidelines are already underway across the country. Before the implementation of Universal Health Coverage Benefit Package, we are doing an assessment of the healthcare facilities which have been selected for the implementation of UHC benefit package. And that assessment is being carried out using the service availability and readiness assessment tool of WHO. And as per our requirement, we have included a module on safe abortion and post-abortion care in this assessment tool as well. And these assessments are right now underway in 12 districts of Pakistan, which are where we are going to pilot the UHC benefit package in the first phase. I just talked of the SRH subgroup, and I also have already mentioned the participation of these SRH subgroups at the federal and provincial level. All these organizations which are included in the SRH subgroup activities, they were there in the consultations which led to the development of UHC benefit package. This slide is just showing the process of development of UHC benefit package. And as I already said that we are among the first countries in the world which have developed this benefit package. For resource mobilization, we are working not only for mobilizing the domestic resources, but also we are hoping our partners to contribute towards the implementation of this benefit package. And one more thing I would like to share is that here in Pakistan, we have a health insurance program which right now covers the services at the indoor level. But now under this UHC benefit package, we are piloting the OPD services, the SRH, the services which are included in the provision under UHC benefit package, including the SRH services. They are going to be delivered at the OPD outpatient level as well through a pilot program. So after getting results of this pilot program, we will scale up the services across the country. So this is what we are right now doing for inclusion of sexual and reproductive health services in the domain of universal health coverage. This is all from my side. Thank you.
Thank you, Dr. Atia. Very interesting and also very impressive what is happening in Pakistan currently and how it's being developing and how UHC is being implemented. We will take questions later and also discuss among the panel. So I will move to our next panelist, to Siva. Siva, could you elaborate more on some of the groups that are marginalized and how does it affect their health rights? And how does it affect also in different regions, for instance, Asia or others around the globe? Can you elaborate on that?
Yeah, thank you so much, Wilbald. I think that when we're trying to engage on this conversation on merging UHC and SRH-UHC together, so we have to remember that universal health coverage for the longest time has been a conversation driven by removing financial barriers in access to health care, and how this financing will be accomplished, right? Whereas in SRH-UHC, the conversation has largely been driven by the conversation around access, which includes non-financial barriers. And this could be the AAAQ, or it can, and also that, in that availability, acceptability, affordability of services and quality. We know that discrimination and inequalities caused by structural and social barriers, which are things like gender, class, ethnicity, caste, migrant status, rural, hard-to-reach locations. These have always posed the defining parameters of this conversation on access, right? So for my part, I thought I would focus on gender and sexuality as the key social determinant and the social norms perpetrated, which pose a challenge. In all of the health services that we have seen, and especially since Veloshini brought up, and this became apparent during COVID-19 especially, right? What are some of the current fault lines that have emerged? I think the one key thing that we need to look at is the marginalization and criminalization of populations and sexual behavior. And this talks about groups like, migrant workers, whether documented or undocumented, sex workers, LGBTIQ communities, right? The second thing is the social norms and social sanctions around sexuality, unmarried young people, LGBT people. And the third is fault line would be the rise in conscientious objections, right? And whether these are with regards abortion, LGBT non-treatment, conversion therapy, or not treating or not accepting, unmarried people as clients, right? And all ramifications on mental health, especially when you talk about conversion therapy. So the socioeconomic inequity perpetuates health inequity, right? And this is especially true for women. So on the first fault line, which is about marginalization and criminalizations of populations, right? If you can look at laws which restrict and discriminate formal and informal, for example, at country level, there were already female workers migrant workers who would be immediately deported when they are found pregnant. If you have a HIV status, you're not able to obtain work permits. And these often drive migrant workers underground to hide their health status or not seek medical attention. We've seen that, if it's women workers, they contribute higher numbers to maternal deaths and complications from delivery because they've gone underground. Migrant workers are very often also not covered by insurance packages, right? So they don't have access to healthcare services, including contraception, family planning, delivery care services, as well as safe abortion services. They may also have very strict family planning policies on refugee populations. For example, in Bangladesh, this was seen for the Rohingyas, right? And this has been noted. And this has also become starkly more apparent in the era of COVID-19, where we have seen especially a rise in xenophobia and anti-migrant and anti-refugee sentiment, across the region. And whether it's about accessing healthcare, accessing social services. So very often these populations had to go underground. And even in a time of pandemic, governments were not able to shift their lenses in order to accept them, even to control COVID-19, right? And they were hunted or imprisoned when they seek services. The second fault line is about social norms and social sanctions around sexuality. So the state has defined sexuality as heteronormative and occurring within marriage. So on the one hand, it provides services to married women and couples, but also in those instances subjected to spousal consent for family planning, tubal ligation, or abortion. And some states in the Asia-Pacific region actually are moving towards criminalizing premarital and extramarital sexuality. So Brunei, Indonesia, Malaysia, through religious laws apply, and this applies in the religious law applies to both youth sexuality outside of marriage and as well as LGBT populations. And in religious law, there's even corporal punishments for this for these misdemeanors as is defined by religious law. On some hand, you also have state-sanctioned conversion therapy programs, which talk about the struggles between ministries of health and religion and who actually makes the decisions around these issues, right? So that's definitely one of those fault lines in UHC and SRHR we are seeing. The last I'd like to talk about is actually, the rise in conscientious objections. So conscientious objections for abortion service provision. Earlier, it was on young women, where religion of the young woman prevents receiving services, or reticence towards providing abortion services, even when clearly warranted to minors, now need to be determined in court. This has been seen in India and in Nepal. There is a social barrier of young unmarried women being able to access safe abortion services. So turning to courts delays the access, and the court turns to medical opinion of the doctor, where access is determined by whether individual is capable of safe delivery rather than autonomy, right? In many countries, we're also seeing conscientious objections to a gay lifestyle, right? So funding HIV services for gay men in a number of conservative societies, taxpayers are saying, well, I don't want my money to go towards that. So what are some of the key takeaways? What these fault lines actually show us is that the uniformity of what constitutes SRH services and who can access SRH services is fragmented across countries. And in SRH, often the most marginalized and most vulnerable populations which need to be covered are left out. These could be adolescents, young people, LGBT, migrant workers, which should be for a litmus test of some form of universal health coverage in the era of leave no one behind.
Sorry, Siva, I'm just conscious of time. I'm sorry.
Okay.
You can just wrap up, that would be great.
Yes, so provision of SRH in UHC context involves a removal, amendment of legal barriers and rescinding of policies and affirming the rights of marginalized groups and tackling unequal gender power relations. And integrated services often also need to look at counseling, information, and education, which is not always available, though they provide holistic care. So thank you. So those were my points.
Thank you, Siva. And I think 3 points that you made and how you brought it together, I think was very elaborate, and it will help us with the discussion later on. I hope that our viewers have also questions around that. And I think it links very well to our next speaker, Ruth. Siva, you were talking about marginalized and criminalized populations, but Ruth, you have, I think, a lot of experience with sex work and sex workers. So what are the equitable access and health service problems for criminalized populations? What are the structural barriers to UHC, and what can we do about it?
Thanks, Will. And I just want to start with a little bit of an introduction to NSWP, because it's going to be new to many people and it will set some context. So NSWP was founded in 1992 to promote both health and human rights of sex workers, female, male, and transgender and non-gender conforming. And that's an incredibly powerful group of people. I think for me, we've worked as NSWP a lot around promoting health, around engaging with WHO on guidelines development for HIV and STI prevention and treatment. And we help WHO, UNFPA, UNDP, World Bank, and I'm missing somebody. Oh, NSWP maybe. But we developed the sex worker implementation tool. And throughout all that advocacy, we've had to really strongly advocate for the need for sexual and reproductive health in a broader view than just the simple HIV and STI lens. Too often my community have been missed out of reproductive health, either by gender or by that we're not fit to be parents. And neither of those are exclusionary from SRH-UHC services. So I think it's really important that we actually look at then, if we're excluded from SRH-UHC, where is the equitable access to UHC? And why are we facing those inequalities? And for those of you that follow UNAIDS, the new global AIDS strategy has put criminalization of key populations. And by that, we're talking about sex workers of all genders. We are talking about people who use drugs of all genders. We are talking about gay men and other bisexual men and other men who have sex with men. And we're talking about transgender people, both trans men and trans women. And the one thing we all have in common is criminalization. And I think it's really important that we actually understand what is it that prevents us from accessing health services. Because that criminalization underpins and exacerbates the stigma and discrimination that my community certainly experiences when accessing health services, when being arrested by police officers, often not to be charged and taken to court. And much of the sexual violence and the physical violence that my community experience actually come from the very people in countries that are meant to protect us, from law enforcement officers. And that research is across all the regions. And we currently have 295 members in 96 countries around the world. So while I may be a white British person sitting in the UK talking to you all, the network, the majority are from global south countries, from lower and middle income countries, where the situation is really dire and there is little rule of law for my community or protection of law. I think the other issue for me that COVID-19 has exposed and will continue to expose for some time to come, I think is the exclusion of sex work being recognized as work. So for many of my community, sexual and reproductive health is an occupational health issue. It isn't just sexual and reproductive health. It's actually about our work and keeping us safe in our work. And unless sex work is recognized as work, we don't get access to the social protections that have been offered to many other people. And even in a country where sex work is legal, in Nevada, in the USA, the US emergency response to COVID excluded even people who work legally and pay taxes in that country from any of the emergency relief. So I think the structural barriers are quite huge for my community. And I'm hoping that we can, as we advocated, as UHC HLM happened, that if we truly mean that we're going to leave no one behind, we actually have to put the last mile first. And for many of us, the people that will never be considered by governments introducing UHC, it is the very people who are actually criminalized by those very same governments and who fail to offer protection of law, protection for social protection, and both natural and health emergencies that arise. Thank you, Will. I hope that shows some light.
Great, Ruth. I think that was really sobering, I would say, a sobering statement that you made, and it really shows, how criminalized and marginalized populations don't have access to services. Thank you so much for that, and I hope we also get questions on what you were saying, Ruth, and go more into detail. Next, we have Sandil, our HIV youth advocate who I was introducing earlier. So Sandil, are young women HIV positive and negative aware, and do they fully understand SRHR services that are available, and what are the challenges that they face? Maybe you can bring it from a young youth perspective, as you said. Oh, you have to unmute yourself, Sandil. You have.
Yes.
Yes, that's perfect.
Yes, perfect, great. Thank you once again, Will. Thank you for that. I think the population of Eswatini is a fairly small population with just over 1 million, and I think I can confidently say that young people are aware of the services available to them, and we see glimpses of that through the 95 global HIV target that Eswatini has reached a whole decade in advance. So in as much as they do cover a small fraction of the people targeted, but there is a sense of awareness. Now the challenge comes with the gaps in between through their awareness. So they are aware, but now the gaps, we're looking at things such as inadequate skill and competence among health providers to deliver this SRH services. Now, as a young woman, I experienced this sort of discrimination or challenge when I try and access my antiretroviral treatment as a young person living with HIV, and trying to empower the young girl and young people to sort of continue and adhere to their treatment. So the biggest challenge here is that the health professionals are judgmental, and of course they are our mothers, which means the cultural barrier at this point has no boundaries. Now, you're a child even at the health center, unfortunately, as a young Swazi woman, and therefore you'll be taken to task for requesting the Implanon contraceptive, because why are you having sex in the first place? This automatically disinterests the child or the young woman in actually trying to access the services that they rightfully should be having access to. Okay, and quickly, also another challenge that is an issue is the absence of the conversations in classrooms where they spend most of their time, and at home, of course. Again, this is yet another cultural barrier that does see young people not being able to be comfortable enough to even inquire more about the services that they need. And I think another thing which is a bit of a challenge is the family planning terminology. And I say this because family planning translates differently to a 16-year-old who isn't planning to have children, but needs information on HIV testing, where all these have been integrated into one and put under the same roof for instance, at the Family Life Association, where is by far one of the only centers that provides a youth-friendly services for me. So now automatically, because there's the family planning element to it, it sort of filters the young person in attending, because that's not what they want. So I guess the terminology somehow there has an issue. Is the government doing anything? Is it assisting? Yes and no. Yes, no, because abortion in the Kingdom of Eswatini is still illegal and is it's illegal. However, in 2012, in October 2012, about 1,000 young women were seen for abortion-related complications, which means this is quite evident that there is an issue there, and there has to be a need and contribution from the government in changing this. And what I would think should be done is quite a lot. For instance, investment in guiding tools for healthcare providers and how we go about engaging the youth in a comprehensive way, and emphasizing the need to dismiss the cultural barrier. So I think these healthcare professionals should be taken to task and put into and really understanding the importance of how they should deliver these services to these young people without pushing them away, right? And there's also community intervention. I have previously worked with Young Heroes, and Young Heroes has 2 interventions that really strike me, and I felt they were very impactful and did change to the barriers that we are facing as young people living with HIV and not living with HIV. One was Insiga ya Kusasa. Insiga ya Kusasa means the pillars of tomorrow. Insiga aims to prevent new HIV infections and to reduce vulnerability amongst orphans and vulnerable children and adolescent women in the Kingdom of Eswatini. It helps those who are HIV negative remain HIV free and supports those who are HIV positive in leading healthy lives, as well as the Health Project. The Health Project aims to halt the spread of HIV and reverse its impact on the Swazi society by targeting youth aged 15 to 24 who are out of school. Now we've seen those young people being neglected because of being out of school and not really having an understanding of the services available to them. And lastly, media and social media, which is my biggest playground as a young woman. It's 10 years ago when I tested positive, it dawned upon me that young people are actually on social media. They are trying to engage and with amongst each other. So why not bring the information that they need to them on these social media streets, and as well as youth empowerment. So my social media pages mainly involve content about self-love, living positively with HIV, thus promoting HIV disclosure as well, and discussing the importance of HIV prevention, and often narrating the trips to the ARV department or a healthcare service, so to normalize and reinstill that it is okay to go to the healthcare center. Right, as well as whether it is sharing the other options of HIV prevention, PEP and PrEP, which is not so familiar. We've seen quite the gap there because there's often questions after sharing. There's often questions that where can I actually access this type of prevention method, and
just have to wrap up, Sandil. So
yes.
Any final word?
I think that will be it for now. Thank you very much.
Thank you, Sandil. And what resonates with me is the pillars of tomorrow. That's what you mentioned. And I think that's something, we young people are an investment for the future and the pillars of tomorrow, actually. It's a very good statement. And it links also very well to what you were saying, and social media. I hope we get also some questions around that later in the discussion. And now I'm turning to Jacques. Jacques, being in South Africa, what are the main challenges that the COVID-19 pandemic has brought to you in terms of advocacy on SRH-UHC for young people, and what can we do? What can international organizations do? What can governments do to improve the situation? Over to you, Jacques.
Thank you very much, Will, and good afternoon to everybody. I think let me start with some background and also sharing, an experience that we are having in the country that sort of, maybe in a way sort of ties population policy considerations all the way through to young people and SRH-UHC and come back to the questions that you've raised. First of all, our population policy is based on our country's population policy is based on the sort of, I suppose, almost like usual nowadays, principles of reproductive rights, gender, etc. But an interesting thing is that one of the guiding principles of our population policy is the involvement of civil society in the design and implementation of population programs, which I think is something that one doesn't always find in government policies. The policy was adopted to address a range of concerns, but including concerns that are related to young people's sexual and reproductive health and rights, for example, teenage pregnancies, maternal mortality as a consequence of high-risk childbearing, and sexually transmitted infections, of course, as well. So to implement the policy, a whole range of strategies were conceived back then, which is more than 20 years ago, including to promote responsible and healthy reproductive and sexual behavior amongst young people, and then obviously advocacy on gender and also equality of men and women when it comes to responsibilities in relationships and households and so on. So to give effect to this foundation that was basically laid by the country's population policy, and maybe I can just ask Dikshita to start sharing the one slide that I brought along. To give effect, we've developed jointly, government departments as well as civil society organizations and young people, a document that is called the National Adolescent Sexual and Reproductive Health and Rights Framework Strategy, which was approved by our cabinet in 2015, which basically tries to pull everything together that has to do with adolescents, SRH-UHC. There are so many sectoral policies and strategies, and I think about a dozen pieces of legislation that bear on young people's SRH-UHC. So this framework strategy didn't create a new policy or yet another one, but it tried to sort of pull it together and involve different stakeholders from different sectors, as well as the young people themselves, etc. Amongst the objectives and programs of this framework strategy is an objective that basically says to create effective community supportive networks for adolescents. So that is almost like outside of the system, etc., etc. We then, in order to sort of get those, what was done by national and provincial on the sort of in the frame, but also research and evidence that was done on HR, existing mechanisms, community and youth sexuality services to people and to speak to young people in the context of their communities was embarked on at a very local level. That was called the Ezabasha Dialogues, which is the Zulu language, which means for young people. So in a dialogue, people would literally be invited to come together and start talking about SRHR issues of young people. So it'd be old people, young people, service providers, parents, grandparents, etc. Very quickly, out of those dialogues, what happened was many people wanted then to take action in their communities. Say, right, but what can we do? How can we change things and so on? And we realized that, from a single dialogue session for somebody to really become an active change agent in his or her community, some training needed to be provided as well. So we developed the training program, which is the sort of next level on the pyramid, into which we invited the energetic volunteers who came out of the dialogues into a formal 1-week session where they would be trained on what are the key issues, the key concepts, and so on. And of course, the trainees didn't want to lose touch with each other after the training. They wanted to continue engaging. They wanted sessions where they could come together and make plans together with other young people from other parts of the country. And that's where we then connected with an organization called Partners in Sexual Health, which is a civil society organization that works in the area of SRHR. And we started convening them into camps. So young people would get together, they would lead the camps, they would formulate strategies and activities and interventions and so on. And the young people themselves then out of this built a network. So these camps then got a name, and the network got a name, which is Siyakwazi, which is the Xhosa word for we can. From there, social media got involved, etc., and a countrywide network of young people was built to drive SRHR of young people, and then to basically sort of build effective community supportive networks for adolescents. Now, I see my time is up, so what I'll do is, in the follow-up, I'll come around to the specific questions that you've asked. But I thought, this experience was quite worthwhile sharing, because it's literally an experience of where thinking at national government, just through a sort of organic process, led to a groundswell of youth-led activities in the area of SRHR in the country. Thank you.
Thank you, Jacques. Yes, you could. Yes, perfect. Okay, that's great. Yes, so I think that we thank you so much for the panelists for for bringing your views and to bringing such a wealth of answers, but also raising more questions. So that will be really great. That has been really great to hear. I was thinking, I think we have 2 questions from the audience, and I'm just looking at the chat. I hope I can get them, but it will take time to copy and paste. So one question, I just open it up to the whole panel. How can we ensure access to skilled breastfeeding counseling? For access to international board certified lactation consultants? That's one question. And the second question is, in the light of religious and civil laws, how can we increase the inclusion and recognition of sexual reproductive health and rights as part of UHC? So the first question is on how ensure access to skilled breastfeeding counseling. And I would think also maybe in the context of COVID. And the second is on inclusion of religious civil laws in SRH-R and part of UHC. Someone from the panel wants to take one of those questions? Just raise your real hand. I can see it if you raise your real hand. No need to use the Zoom hand. Yes, Dr. Attia, go ahead, please.
Yes, thank you. Regarding the access to breastfeeding with skilled workers, Here in Pakistan, we have lady health workers and community midwives who are working in the community. The lady health workers go from door to door. Their basic mandate is to provide health education regarding the maternal and newborn and child health. And apart from this, they do so many other things, but their basic mandate is MNCH. And under this provision of these lady health workers, they are also, as they go from home to home, from door to door, they provide education to the women, not only for their self-care, how to manage them during their pregnancy, but they also do educate them regarding the breastfeeding practices. And similarly, the community midwives, they also keep on educating the women about the breastfeeding practices. So the access is quite reasonable here in Pakistan, and we have shown, we have documented progress in the breastfeeding in our last demographic health survey. And we are also considering the expansion of these lady health workers workforce here in Pakistan. So it is it's not a big challenge here to improve the access for breastfeeding. Thank you.
And I think this links to what you had in your presentation, saying that integration is key, and it seems to be integrated well, which I think answers the question. The second question, Ruth, did you have your hand up? I saw you flicking up your hand.
I did. I thought I might take this one because I think the failure to recognize sexual rights within the SRH without the R, I think is really harmful to UHC. When you are denied your sexuality, when your gender identity is denied, as we're increasingly seeing today, there is a whole movement that is challenging gender identity. I think that drives all of us that are marginalized or criminalized away from SRH care and also from UHC. And I think, as I said in my comment, at the end of my comment, for me, we have to put the last mile first. And those who are excluded from having sexual rights, and that includes women who are denied access to safe abortion, in my mind. It includes the right to decide whether you have children or don't have children, and to have access to them. But I think these are rights that we are denied in many countries. And we have to put the last mile first if we're going to leave no one behind and actually achieve universal health coverage for all. Because the stigma and discrimination about when you have your rights denied keeps us away from what we're all trying to achieve, which is health for all, with no exception.
Thank you, Ruth. And that links also to what you're saying, that some women in some countries are denied COVID, support during COVID. So that's also a right, I guess, right? So thank you so much. We have now a third question, and this is how does the, maybe I take two and then I open it up. The first one is, how does the comprehensive sexuality education play into SRH-R and UHC? And the second one is, how can we ensure access to health services for criminalized populations, sex workers or migrant workers? So the first one is, sexuality education. And the second is on criminalization. I was thinking, since Ruth has spoken, maybe Siva, you want to take the criminalization population. The question is on migrants, actually, if that's okay. You want to kick off with the second one, Siva?
Yeah. Actually, I also wanted to talk about comprehensive sexuality education. This is very simple, exactly like what Ruth has actually said, right? The fact whether universal health coverage as a concept can actually be something that promotes the health and well-being of our whole population rests on the fact that those nations or our nations are respecting human rights. That's one, right? But it also means that universal health coverage, when it's rolled out, needs to have a supporting architecture. So comprehensive sexuality education is definitely part and parcel of SRHR. It's going to help young people and adolescents realize and achieve their sexual and reproductive health needs, right? And as well as prevent things like gender-based violence. But that also means that the Ministry of Education is one of those stakeholders that need to be integrated into a universal health coverage package, right? And in the same way, I want to talk about things like vaccination, like, for example, cervical cancer vaccinations, right, or HPV vaccinations, are something that is carried out at school level through the Ministry of Education, working together with the Ministry of Health. So universal health coverage also means that we need an intersectoral kind of architecture in place to make sure that the programs that are being rolled out at country level do not actually widen the inequities, existing inequities, but help bridge the inequities that exist, right? I mean, that's our aspiration with universal health coverage. The other one I want to talk about is, like, for example, access to health services for these criminalized populations. Every country does work in health, I have realized, things that they publicly talk about and things they don't publicly talk about for fear of raising public ire, you know. One of those things which we know is being done for whether they are refugees, migrant workers, documented or undocumented migrant workers, is tuberculosis prevention, right? So we know that Ministry of Health, that even very repressive countries go out and treat and give medication to undocumented migrant workers because they want to prevent a TB outbreak. Now, if we can have this kind of framework and approach to all of the health services, then, you know, it's much easier to accomplish. So I wouldn't say that this is not happening at all in the field of health. It is, but it is happening in sporadic areas which the government thinks is critical to them. So if we can actually build a framework of inclusion based on these kind of smaller interventions that are being made, this is also will be helpful, I feel, to that bringing those who are now excluded and bring them into the universal health coverage framework.
Thank you, Siva. And I see Jacques here raising your hand. Go ahead, please.
Yes, thank you. Well, I think just also to build a bit on Siva's intervention on comprehensive sexuality education and share a bit of our experiences. In my country, we have that sort of intersection through something that's called the Integrated School Health Program that links the education system to the health system at local level, which theoretically is very nice. But one of the sort of observations that we've made, you know, in dealing with sexuality education content and delivery by the education system is, you know, this interesting observation that for a teacher to become a mathematics teacher, the teacher has to be qualified in mathematics, or a language teacher has to be qualified in language. But to become a life orientation teacher, who implements a curriculum that deals with sexuality education contents, there is no sort of specific requirement, nor is there something specific that somebody can go and study and then come out of university as a qualified life orientation and sexuality education teacher. So what happens in our schools is that so many of the life orientation and sexuality education teachers have no formal training in what they have to do. And obviously, you know, in the school dynamic, the teacher does not simply stand in front of the classroom and teach us stuff. A good life orientation teacher would then be the person to whom young people come with their problems that they experience at home or in relationships and all their questions and so on. But the teacher has not been formally trained in an accredited way to do that work. So I think that has to be flagged as well, is that when one talks about strengthening systems around CSE, at the core of the system, one has to strengthen the core individuals who are responsible for delivering it. Now, the other thing that, you know, I think we've heard and seen in many developing countries, and definitely in Africa and South Africa, is since COVID came, on the one hand, in the health system, the system became overburdened. So either people could not access SRH services, or people were scared to go and look for SRH services. But now, on the other hand, for long periods of time, schools were closed. And what we, for example, in the government did very smartly through the Siakwazi Youth Network, incidentally, was to move to social media and say, well, you know, we can still get loads of information to young people. But reflecting over the past year, what we realized was the loads of information mainly reached young people who live in urban areas and who are not the poorest, young people who have data on their mobile phones, and young people who have smartphones, which means that poor young people, especially in rural areas, ended up being left further and further behind. And I think when one holistically looks, you know, at the whole system thing of health and education, etc., one has to keep in mind that COVID particularly, you know, has exposed some of the cracks in our societies and has led to many people being left further behind. And we'll have to make plans on how do we, you know, assist them to catch up again. I'll stop there. Thanks.
Thank you, Jacques. And that links also to another question that we have. And it's very good to hear the South African experience. The other question is around young people in social media. So Sandile, I think we lost her. She had connection problems. But can any of the panelists speak to social media involvement and how we can involve young people, but also marginalized populations better through social media? Ruth, please go ahead.
So I just want to echo what Jacques was saying, because one of the things that COVID has forced us all to do is to attend so many Zoom meetings constantly, every hour of the working day and night, it seems, at times. But there is a huge digital inequality, not just between urban and rural, but between rich and poor, between privileged and those that have no privilege, between education and those that have little education. And that particularly affects marginalized communities. And I think I am super grateful for social media and enabling us to get our message out. But I think if we're going to do community mobilization on the ground in every country, which is what we need, we can't just rely on social media. Building communities and building organizations led by communities is one of the strategies that's been acknowledged within certainly the global AIDS strategy, where it says that a percentage, and I think it's 60%, of services should be led by communities, including community health workers, but not only community health workers. And within my movement, I'm sad to say that earlier today, I heard of the passing of one of our leaders in India from COVID-19. She was part of a sex worker collective of all genders in Mysore in India. Name was Manjula. And they actually trained sex workers to become nurses, and they ran their own clinic and they employed their own doctors. And there were 12 sex workers who went through nursing degrees and worked in their own clinics. There are sex worker-led organizations in South Africa, in Pakistan, in Thailand, in Eswatini, across the world, who need to be part of our health response, including sexual and reproductive health, and the task shifting that's required to make UHC a reality for all. Thank you.
Thank you, Ruth. And that answers also one of the questions we had, you know, how can we advocate better for marginalized populations? How can they be better heard? And I think you exactly spoke to that. And it's true, I think that not everyone has access to, you know, social media or even to certain connections that are so crucial now. Again, it shows the inequities, as you said. And Sandil, I hope you can hear us and you can speak, because we were missing you, because you had to drop out because of connection. We had one question, and I hope that you can elaborate on that. It's the social media. The question was, how can we better and how can we use better social media? How can we reach young people more concretely? Because you mentioned it, I think, in your statement. Can you talk a little bit more about how social media can be used to reach marginalized young people?
So, as Ruth has mentioned, social media on its own is not enough, correct? And hence I outlined the different interventions that then take place in the community, because you're looking at two groups here. You're looking at the social media streets, which is what we call it, and you're looking at the actual community. So the social media element joining and integrating with the community is just another way of reaching out to that group that is not necessarily active in the community and wanting to join conversations where there are group discussions and so forth. So you just place the information. And another thing that usually assists is the modeling of a person that is living or is experiencing the issues that they are currently facing, which has been my biggest attempt and greatest attempt is trying to show the young people on social media that the challenges that they are facing, whether they choose to read through and access or not, it's really their decision. However, we cannot fully eliminate the social media aspect of it, because they are on social media and they are engaging each other in social media, and they are DMing and sending messages to people like me who play a role of bringing the information to them, the information that they are not being able to access at the healthcare facility. I hope that makes sense.
Yes, absolutely, Sandhya, and that's I think that answers the question. That's really great. Yes, and social media will become even more important, I guess. So we would have to deal even more with that. There was a question that we had, and I just have to go up here. Yes, what's the role of private sector in making inclusion of SRH and UHC a real possibility? And maybe Veloshini, you want to respond to that question, maybe also from a WHO perspective, I suppose.
Sure, thanks, Will. I mean, I think I can speak to you from a global perspective as well. I think the role of the private sector, as we know, is extremely significant across all settings, whether it's a high income, low income, developing country, middle income setting. And the role of the private sector is significant both in terms of service delivery, service provision, increasingly in terms of very pluralistic health systems, in terms of even health financing, as we know, when we speak of private health insurance. And this itself also has implications for inclusion of sexual and reproductive health in the context of universal health coverage. And I think I think it's a huge topic which we probably will need a separate discussion on around the role of the private sector. But I think important to say is to recognize that across many settings, and I think this will apply to all the participants on this call, is that the private sector can often play a role which, in terms of access, privacy, questions around confidentiality, geographic access, convenience, that the public sector may not be able to play in certain settings. And this we see quite apparent when it comes to access to services for adolescents and the youth, that even if there's questions around fees, users, women, youth, unmarried women may seek care in the private sector just because questions around confidentiality and privacy can be assured. And I think this also leads to a bigger question around is how do we work with and engage the private sector in a way that also improves access to quality services. So what we do know is that, yes, while our populations and those that are marginalized and that are vulnerable will seek care from the private sector, issues of quality of care remain. And that's something that, it's something we need to pay attention to, given that particularly in low-income settings, and probably I think many of our speakers and participants can speak to this, is questions around regulation, quality of care. That's a very diverse range of providers that may not be accredited, that engaged in the informal sector again, but that are important service providers. And I think it's an incredibly important discussion, even from a universal health coverage perspective. One is in terms of financial access, but also more importantly, and I think that's come up in this call quite often, is when we speak of rights, is questions around quality of care, accreditation, respectful care, which are as important for universal health coverage, and of course central to access to comprehensive sexual and reproductive health. Thank you.
Thank you. Yeah, that's really a good conclusion actually of that topic, and also it has answered the question well. Thank you, and gives also the global perspective. I think that's very important. Just a final question, and we have only a few minutes, so we can maybe just answer that. The question from the audience is, are healthcare workers included as stakeholders in the planning and implementation discussion? I think this is an important question that we might want to answer before we wrap up. Someone wants to, include, yes, Dr. Ayatollah, please go ahead.
Thank you. Regarding the participation or inclusion of healthcare workers in the planning and implementation process of universal health coverage, as I already said that Pakistan is among the first countries which have adopted the DCP3 recommendations. We have developed the universal health coverage benefit package, and the whole process, it actually started way back in 2018 when it was decided that Pakistan is going to develop such a package to reach the population. And right from the beginning, we have included the healthcare workers in all the meetings, in all the consultations, and also in the governance structure which was created for development of this universal health coverage. We have technical working groups in all the areas of health, like in RMNCH, communicable diseases, non-communicable diseases, and health system, which are the four main components covering all the clusters of health in the DCP3. So we have technical working groups, and these technical working groups do include clinical experts and healthcare workers, not only from the tertiary care hospitals, but also we include from the community health workers as well. And similarly, apart from these technical working groups, the structure, the governance structure included the National Advisory Committee, and then the steering committee, and finally the highest forum. So at all levels, these healthcare workers have been involved in all the consultations that led to the development of the universal health coverage. And it is crucial to involve these healthcare workers not only in the planning but also in the implementation, because they are actually those who are going to provide the services to the population. So it is, I think we have been successful in including the healthcare workers in all the process of development of UHC benefit package. Thank you.
Thank you so much. And it shows that there's really involvement, or we have to involve our colleagues from the grassroots level and health workers to be really part of this. I need to wrap up this session, although I'm also excited, and it's really interesting to hear the questions, but also how the answers. As a wrap up, I want to thank you. I want to thank the panelists. It was really great to have you on, and it was great to hear from South Africa and from Pakistan the real, things that are really happening on the ground, and the integration part, but also when we heard from Jacques around how education can be integrated with health, and also from Dr. Attia, how health workers are in the center and how the integration piece is so important to advance UHC. We heard from Siva the importance of marginalized population, how to include the migrant populations came up quite often, and also how we can include them. And thank you, Ruth, also for your perspective on sex workers specifically. I think that really gave a lot of spice to the discussion. And Sandile, thank you for your input from a young person's perspective. Many here on the panel are, well, at least I'm not so young anymore, but it's always good to see someone with new, fresh mind. And I think your ideas around social media and how we can integrate and how we can, help marginalized populations was really great. I really thank you. I'm excited myself, and I'm sad that I have to wrap this up. But I thank you so much. Just for our viewers as well, we thank you for listening and for watching, and also for sending your questions. It really helped spark the discussion. Just a few reminders in case you missed any of the discussions today. The event is being recorded and will be on the Wilson Center page for 24 hours. A summary of today's event will be available soon on .com column of the blog, New Security Beat. And yes, I just thank you. And I also want to thank Beloshni and our WHO colleagues. I want to thank our colleagues from the Wilson Center. And I also want to thank my team in UNFPA for organizing this and for all the help. And I wish you a very nice day wherever you are on this planet. Bye, everyone.